All right, welcome to this authoritative explainer on cystoscopy coding. Look, if you are tired of frustrating claim denials and those incredibly confusing bundling edits, you are in the exact right place. Today, we're breaking down the diagnostic versus therapeutic coding rules in urology, delivering a clear, rule-by-rule masterclass. We're going to bridge that gap between what actually happens in the operating room and the CPT framework, giving you the absolute confidence to master these codes and, most importantly, secure your compliance. Let's get right into it. Here's our quick roadmap for today. We'll start with the core rule, move into clinical indications and scopes, then tackle biopsy and lesion sizing, followed by upper tract biopsies and stents, and wrap up with a quick knowledge check. Let's kick things off with Section 1, Introduction and the Core Rule. So the absolutely crucial point to grasp here is what we call the golden bundling rule. CPT code 52000 is your diagnostic cystoscopy. Its entire purpose is just to inspect the urethra and bladder to spot abnormalities. If the physician goes in, takes a look around, and does literally nothing else, you code 52000. But the exact moment a therapeutic intervention happens, whether that's a biopsy, a fulguration, or placing a stent, that initial diagnostic look is instantly bundled. Violating this rule by billing 52000 alongside a therapeutic code will guarantee a denied claim, every single time. Moving right along to Section 2, Clinical Indications and Scope Technology. Now, think about the physical differences between the two main tools urologists use. You've got the flexible cystoscope, which is a pliable fiber optic tube, and then you have the rigid cystoscope, which is essentially a straight, solid metal telescope. Just by checking the operative report to see which specific scope was used, you immediately get a massive clue about whether you're heading down a diagnostic or a therapeutic coding pathway. The choice of scope is totally driven by the patient's needs and the clinical setting. A flexible scope, that's all about patient comfort. It's usually done in an outpatient clinic with just a little local anesthetic gel, perfect for diagnostic surveillance like checking out gross hematuria or recurrent UTIs. A rigid scope, though, really means business. Because it's straight metal, it usually requires regional or general anesthesia in a proper operating room. It has larger working channels, meaning the surgeon can actually pass instruments through it to perform therapeutic interventions, things like taking a biopsy or stopping active bleeding. All right, let's dive into the details in Section 3, Bladder Biopsy and Lesion Sizing Rules. Now, before we get into fulguration, just remember that a standard biopsy without any fulguration is simply coded as 52224. But when a surgeon actually performs fulguration on a bladder tumor, CPT demands we code strictly by size. You'll want to commit these breakpoints to memory. If the tumor is small, meaning 0.5 centimeters or less, we use CPT 52234. If it's a medium tumor, ranging from just over 0.5 up to 2.0 centimeters, we bump up to 52235. And for large tumors over 2.0 centimeters, it's 52240. The absolute vital thing to remember here: these size-based fulguration codes apply whether a biopsy was taken during the procedure or not. Size is your ultimate guide. So what exactly happens if the surgeon does a biopsy and a fulguration in the exact same session? Well, you have to interrogate that operative note. If the doctor biopsies a lesion and then fulgurates that exact same lesion, the biopsy is bundled right into the fulguration code. You only report the size-based code. However, if they biopsy one lesion on, say, the right wall, and then fulgurate a distinctly different lesion on the left wall, you get to bill both. You report the fulguration code plus the biopsy code, but you absolutely must append modifier 59 to the biopsy to signal to the payer that these were totally separate sites. Before we move on from biopsies, let's clear up a very common trap. Coagulation performed solely to control bleeding at a biopsy site is just standard surgical practice. Never, ever code for fulguration if the surgeon is just cleaning up their own mess to achieve hemostasis. That work is entirely bundled into the biopsy code itself. Next up, Section 4, Upper Tract Biopsies and Stenting. If the physician goes beyond the bladder to perform a biopsy of the ureter or the kidney itself, which often involves urethral catheterization and a brush biopsy, you need to lock in CPT 52007. And here is a major pro tip. Laterality matters immensely here. If they brush biopsy both the left and right sides, you must append modifier 50 to reflect a bilateral procedure. That ensures accurate reimbursement for the double effort. Visualizing the anatomy really helps here. Think about how a double J stent curls perfectly in the renal pelvis up top, runs all the way down the ureter, and then curls again in the bladder at the bottom. Knowing exactly how it sits perfectly explains why precise operative notes are so critical. It is a highly specific procedure that demands meticulous documentation. In fact, to properly code for that stent insertion, you essentially need a 5-point checklist straight from the operative note. You need the laterality, the specific size and length of the stent, confirmation that a guide wire was used, confirmation of fluoroscopic guidance, and a clear note stating that the proximal and distal curls were properly positioned. If your physician's operative note is missing any of these 5 mandatory bullet points, query them immediately before you even think about dropping that stent code. All right, Section 5. It's time for a quick knowledge check to test your skills. Okay, you've learned the rules. Let's see how you do. We're going to apply these concepts to 4 rapid-fire clinical scenarios taken directly from the field. Scenario 1. The surgeon performs a rigid cystoscopy and fulgurates a 1.2 centimeter bladder tumor. There is no separate biopsy taken. Think back to our sizing rules. What code applies to a 1.2 centimeter lesion? Exactly. 522355 is our medium lesion fulguration code, which perfectly captures that 1.2 centimeter tumor. Okay, scenario 2. A patient presents to the clinic with blood in their urine. The physician uses a flexible scope to simply take a look around the bladder. No biopsy, no fulguration, absolutely no intervention whatsoever. What's the code for this one? Spot on. This is the absolute classic presentation for a basic diagnostic cystoscopy, CPT 52000. Let's try scenario 3, and this one is a bit tricky. The surgeon takes a biopsy from one bladder lesion. Then they move to a completely separate, distinct lesion and fulgurate it. How are we coding this? Because these are 2 distinctly different anatomical spots in the bladder, we actually get to build both. You assign the size-based fulguration code for the treated lesion and the biopsy code for the sampled lesion. But remember, you have to use modifier 59 on that biopsy to bypass the bundling edit. All right, final scenario. The surgeon goes in, performs a cystoscopy to inspect the area, and then successfully drops a double J ureteral stent under fluoroscopy to treat a stricture. How are we coding this entire session? If you remembered our golden rule from the very start of this explainer, you know we code the therapeutic stent placement only. That initial diagnostic look with the scope is completely swallowed up by the therapeutic intervention. You totally nailed it. By understanding these precise rules, from scope types to lesion sizes and strict bundling laws, you are fully equipped to defend your codes and maximize accurate reimbursement. But as medical technology rapidly advances, ask yourself, is your practice's documentation evolving fast enough to keep up with the next massive wave of CPT edits? Something to seriously think about. Stay sharp, keep interrogating those operative notes, and remember, like, share, subscribe to Decode Healthcare with Harshal.